Guerrero. This is my patient Kendra Channing, and we're going to start off by doing distortion analysis. So I'm going to sit down. I have my patient stand, and I'm looking at her acromion with my thumb, and I'm having my patient have her arms to her side, eyes closed. And with my thumb on her acromion, I'm looking for any A to P sway that's greater than 1/4 of an inch. And if she does have that sway, that places her in a category 1. Next, I'm going to have my patient face the wall. I'm going to put my thumb at the S2 tubercle. Her eyes should be closed, arms to the side. I'm looking for any side-to-side sway greater than 1/4 of an inch. If there is, she's a category 2. For category 3, we're looking for an antalgic lean, and it appears that she has none. But if there was an antalgic lean, that's usually accompanied with some type of sciatic radiculopathy. So next, we're going to do first rib palpation. So I'm going to have my patient sit down. Going to find the first rib tubercles. Then I'm going to have my patient fully flex forward, and extend, then flex forward again, and extend. And what I'm looking for is any hypermobility of any rib tubercle. Category 1 would be both rib heads are hypermobile. Category 2, you have a unilateral rib head hypermobility. And then the category 3, there's no rib head hypermobility. So next I'm going to do my cervical indicators. So I'm going to have my patient lay down, and I'm going to palpate the spinous processes and the TVPs of all cervicals. For category 1, we're going to have bilateral pain or tenderness at the lamped junction of C3. For category 2, we're going to have left lamped tenderness at C4. And then for category 3, there's going to be tenderness throughout all the cervicals. And if there's a tenderness on the spinous process, that indicates that there's a lumbar TVP inferior. And then if it's tenderness in the TVP, that's going to be a lumbar rotation. Cervical compaction test. So now my patient lay down. I'm going to lift her head off the table. And then I'm going to ask her to place her feet together and then try and lift her legs up 18 to 24 inches. And so you're just going to kind of note to see how hard that was for you. Next, I'm going to compress the cervical spine, have her place her feet together, and then try and lift the legs again. And lower. Now, was that harder or easier?
Easier.
Okay. Well, I think she lied, but if it's easier, then that indicates that there is a primary cervical problem. And so to correct this, we would use the cervical stair step. And so what I'm going to do is I'm going to compress the head and then go through a P to A arc. What I'm looking for is a clunk at 4 steps, and she had all 4 clumped together. If there was any type of smooth movement, that indicates that there's a subluxation at that level. So to correct the T1, C7, the first step, we would do an anterior from T1 to T4. And for steps 2, 3, and 4, we would use the figure 8. So I would find where that smooth portion was, and I would go through a figure 8 with her. So say there was one at step 2, I'd bring her here, and then go in a figure 8 motion like this. And that's how you do the cervical stair step. Now for basic 1, I'm going to get my fingertips. Going to be just inferior to the superior nuchal line. In basic 1, this is for a category 1. You're just wanting to balance the CSF flow. And so I'll just wait here until I feel even pulsations throughout all 8 fingertips. For basic 3, I'm going to palpate the sagittal suture for any nodules. Then if the patient had any tenderness, I would place my thumbs on the opposite sagittal suture and then my fingertips on the parietal ridge. So this is done for 3 respirations. So I'd have my patient inhale, then I would try and lift the parietal ridge while tractioning lateral on my thumbs. Okay. Now for the psoas test, I'm going to, can you de-artifact your thing for me? Thank you. When I have my patient lift the arms up, I'm going to traction on the forearms, and then I'm going to bring the fingertips together. And she has a shorter left hand, so that indicates she has a shorter psoas on the left. So I'm going to come contralaterally, going to bend this knee, and I'm at the level of the pelvis, and I have to reach through your knee, so I'd ask for permission. And with the inferior hand, I'm going to stabilize the pelvis. And then with my superior hand, I'm going to contact the belly of the psoas. And I'm going to have her take a deep breath in. And then I'm going to apply slight A to P pressure. And then with each breath in, I apply more pressure. And then on the third one, I'm going to friction the psoas belly. And that is for a category 2 patient. Now for the anterior iliofemoral ligament test, I'm going to come to my patient's feet. I'm going to internally rotate the legs. And I'm looking for a 45-degree angle on both. And the one that doesn't go 45, which happens to be her left side, that's where the problem is. So once again, I'm going to come contralaterally. I'm at the level of the pelvis, and then I'm going to ask my patient to rotate her foot in, and then I'm going to contact the superior trochanter, the greater trochanter, and then she's going to slowly externally rotate the leg, and I'm going to pull. We do this 3 times. On the 3rd time, I'm going to ask her to rotate the leg in, and then quickly externally rotate as I do a quick stretch on the greater trochanter. So go ahead. Now for the arm fossa test, I'm going to have my patient extend the arm, make a soft fist, and this is just my pre-test, so I'm ask her to hold. That feels good. I'll come over here and just go ahead and pre-test both arms. Hold. That feels a little weak. So if we're testing the right side, I'm going to ask you to hold your arm up, make soft fist, find your umbilicus. Is it alright if I palpate you? So I'm going to touch the inguinal ligament, the upper and the lower on the right side. I'm going to get my 4 fingers on the upper part of the inguinal ligament. I'm going to ask her to hold, and then I would touch and then pull. And I'm looking for any lag or weakness, and there was none. Then I would contact the lower part of the inguinal ligament, have her hold. I'm going to touch and pull. There was no lag or weakness. And I'm going to repeat this on the left side. It's alright if I palpate you. Okay. So I'm going to have you hold your arm up, go and hold, or go and find your umbilicus once again. Alright. Hold, and touch, pull. There's a little weakness there. Hold. I touch the lower half, pull, and that's it.